So I'll present first the imaging part of the pulmonary. Yeah, yes, thank you. So quick. Okay, so we have multiple modalities that we can assess pulmonary valve. Echocardiography, MRI, and CT. This is the echocardiography. We know that the echocardiography has 2D so that we can see the function of the LV and RV. We can see also by the sizing of the RV and, which is a bit not very accurate. And then we can see also the jet of the pulmonary valve, and we can have an idea about what is the cause of the pulmonary dysfunction. One important point about assessment of pulmonary valve, that you have to have multiple views to assess the pulmonary valve. So, and the jet can be so laminar that you have to make sure that you use also color Doppler and spectral Doppler to see the severity of the regurgitation. But still, I think because of the position of the pulmonary artery, it is a bit difficult to assess the pulmonary valve by echocardiography. That's why we tend to request cardiac MRI, also for the sizing of the right ventricle and also and the function of the right ventricle. Both are in the guidelines for the intervention like indication. We can do it in short axis or in the axial, and then we can trace the endocardium to assess the volumes and ejection fraction exactly. But what the strength also about the cardiac MRI is about the assessment of regurgitation, because you can see here, this is in the red, this is the flow of the aortic, and it is all forward flow. But if you go to the pulmonary flow, it is forward and backward. And by comparing the forward and backward, we can give exactly what's the pulmonary regurgitant volume and fraction. And again, MRI is good, and for assessment of the function of the RV and also for the function of the valves. We can also give contrast, and we can assess the pulmonary circulation starting from the main pulmonary artery to the branches, and we can have fairly accurate assessment. But I think the most important imaging modality to assess the RVOT and the pulmonary circulation is CT, where you have an excellent 3D data set. You have very accurate delineation of the shape and the length and the sizing of the RVOT, proximal, more distal, and also the branching. Because it's very important to know what is the shape of this complex pulmonary vessels, because those are congenital, and most of the time they are multiple times they have interventions. And you can have also assessment of multiple levels. You can see the length of the main pulmonary artery, because if there is a platform that is very big that cannot fit in this length, it is not good. And you can see how much calcification there. You can see how many, what is the relation with others, with other adjacent structures, especially the coronary arteries, where some platforms are very important to make sure that the coronaries are away and not compromised. We can also put a virtual valve there, whatever the valve available, and you can also see if that valve can fit nicely without any complications. So this is our patient that's going to be discussed by Dr. Bandar. And so this is the shape of the pulmonary artery, and those are the measurements. And also in their report, they also put a virtual valve, and Dr. Bandar is going to discuss all about the case.
Yeah, thank you very much, Dr. Ahmed, about this very nice talk. Actually, we as a structural cardiologists, when we are reading the cardiac CT for the TAVI, there is some point we need to concentrate on it, like the coronary height, the sinuses, the STG. Here of the pulmonary artery, exactly, it's almost the same. Number one, we'll start from the pulmonary artery. You will try to choose which one to put the wire in. Is it the right pulmonary artery or the left pulmonary artery? The right pulmonary artery or the left pulmonary is almost the same, but you want something which is less angled, so it will be very easy to deliver the valve through it. This is number one. Number two, you want to know exactly the RVOT. When we say RVOT, we need this pulmonary artery. Is it in the range to be covered with balloon expandable valve, like the sapien valve or the my valve. So usually you put like a cover stent and to put our stent, our valve. But actually there is a limitation because we know that the sapien, which is approved for the pulmonary valve, there is only you can put 29 and to cover 30. But what about the patient who is having very large RVOT? And actually it is the majority of the patient. So in the past we don't have any other choice other than the surgery. So you will put like a surgical valve or the conduit, and in the future you can put another valve inside it. But in the patient who went for, let's say, batch repair or valvotomy with very large RVOT, in the past we don't have any other choice. But now we have with the self-expandable, as you mentioned, the Harmony, the venous P valve, the Altera, which can give the majority of these patients. So this is number 2. Number 3, which is very important, the proximity of the LAD to the pulmonary artery. Because the concern that sometimes if it is very close to the pulmonary artery and you deploy your balloon expandable, you will compress the LAD. So you want to be sure that you are far, and as Dr. Ahmed he mentioned, this can be assessed clearly by the CT. But if there is a question, exactly as we are doing in the TAVI, we are doing balloon size. Inflate the balloon, take your orthogram, or engage the lift system and see if there is any compromise or not. And the last thing, which is the RVOT and the place of the anchor and the length of the pulmonary artery. This is I think the most important thing in the cardiac CT. So I will go to our case. Can you share please my slide? So in my presentation, I will try to concentrate mainly about the Altera pre-stent system and the Edward valve, which have been recently introduced to our region. And the last month, actually, we did 6 cases using this new platform, which can help you to address the majority of the patient with large RVOT. So as you see, the idea to try to create an anchor zone to deploy your Edward valve. So as you see here, this is a pre-stent which is covered, and the top of the pre-stent is opened to give you an access to the pulmonary artery, and this will not allow you to compromise the pulmonary artery. Once you deploy your stent, it will be regular valve-in-valve case. It is very easy. There is no any risk to compress the coronary or anything because you are deploying your valve exactly at the waist. So as you see here, there is this top, the top it's mainly for fixation, to fix your Altera pre-stent in the pulmonary artery. Open cell, as I mentioned, to give you an access to the pulmonary artery, so this will not compromise the flow to the pulmonary artery. The sealing zone, as you see here, it is covered. So it is covered from the proximal part and also the distal part, so this will prevent any leak behind the stent. And also the landing zone, which is almost 27. And 27 you will put 29. And we know that your RVOT is supposed to be bigger than this. So there is no any risk to compress the coronary artery. And for sure that already you did your measurement to the CT, but in this platform and also in the Harmony, in the majority of the cases, you don't need to do balloon compression test to the coronary artery. So the inclusion criteria for this large Altera pre-stent, you want to have large RVOT, because in the patient who have less than 27 millimeter, you can put simply cover stent and you can go ahead with your regular Edward valve. But in the patient who is having RVOT from 27 to 38, so you need this new adaptive pre-stent. Altera stent will help you to accommodate 29 valve. And the issue with the patient who is requiring this pulmonary valve replacement, that they are in the 30s. So for sure, they will require every 10 years another valve. So if you send him for the surgery now, so what is the next? So you want to save as much as possible from surgery. So you can put this platform, the Altera, then put 29, after 8 years, another 29, after a year, 29, then you can put even 26. Unless you have high gradient, so in this type of patient, you need to send him for surgery. So you want to minimize the number of the surgical procedure for the pulmonary valve as much as possible. So as you see here, it is very easy to, you will put your stiff wire in one of the pulmonary artery. You will release your Altera pre-stent as we are releasing, let's say, evolute valve. It is very straightforward procedure. And after releasing the pre-stent, you will go ahead and also you will, let me try to, sorry. You will put your Edward valve. And the beauty of this system that already the Edward valve is loaded on the balloon, okay? Because you know it's the vein access, so you can have very large access and inflate it directly. So it's very simple, friendly platform to treat difficult cases in the pulmonary valve. So I'll present our patient. So she is 32 years old, female. She's known case of tetralogy of Fallot, status post-repair 1993. She presented to us with symptomatic free PR, very dilated RV, and ejection fraction was 60%. And already Dr. Ahmed, actually, he discussed the CT. So I will go ahead with the live inbox case, if you can share it with us. So usually in this type of procedure, we need arterial line and one vein axis to put your pigtail, as we are doing this in TAVI, and the main axis, which usually right femoral vein axis. And as we know that all the large bore axis, we are putting 1 to 2 proglide to help you to reach the hemostasis faster. So I will try to skip the proglide because most of us, we are adult intervention cardiologists, so we are familiar with that. Okay, the most important thing here that once you want to cross to the pulmonary artery, you need to use the pulmonary balloon wedge pressure, because you don't want to go through the cords during the introducing of this very large dry seal. So always try to use the balloon wedge pressure, and after that try to bring your stiff wire. Usually we are using a double curve Miller wire, which is very stiff, to deliver your the pre-stent and also your valve. All the time, keep your pigtail in the pulmonary artery. Usually we don't take any imaging before putting our stiff wire, because we know once you put your stiff wire, this will change the anatomy of the pulmonary artery. So you want to take the angiogram once already you are in the, already your stiff wire is in. And as you see here, we choose the right pulmonary artery because it looks straight, comparing to the angled left pulmonary artery. And then after that, we will do regular dilation. And after that, we introduce the dry seal, 24 French dry seal. The dry seal is very important here to help you to introduce the pre-stent. Although recommendation of the company, we can go with 16 French, but I feel really the dry seal is more friendly for use, and also you will need it at the end of the procedure. So we like to introduce it from the beginning. And after that, you will go ahead introducing the Altera sheath. And as you see here, that it is like a small manipulation by pushing the wire to try to deliver it. It is very friendly to deliver it. In the past, when we are delivering the sapien valve, we are delivering the dry seal, 24 or 26 dry seal, which is very difficult really to deliver it comparing to the Altera sheath. So as you see here, this does show you that this is the waist of the pre-stent. You want to start releasing the top of the stent in the right pulmonary artery, and after that try to release it slowly. As you see here, you will counterclockwise the wheel of the pre-stent. During that time, you will need to keep pulling tension on the pre-stent, because it will dive into the pulmonary artery, as we are doing this in the Evolute system. Then you can start releasing it very slowly. No need for pacing. You can recapture it several times actually. And every time you need to check 3 things. Number 1, where is the tip of the pre-stent? Is it impinging on the pulmonary artery or not? Number 2, the waist. You want to keep the waist around the annulus or above the annulus of the pulmonary valve, if there is a pulmonary valve. And also the lower end of the pre-stent. The lower end of the pre-stent exactly at this radio-opaque marker. So you don't want to protrude very much in the RVOT, because this will create an arrhythmia, and also you don't want to be higher because this will create the paravalvular leak. During the release, take your time because you want to be sure that you are completely out and your stent is already fully released. then for sure you have to be very careful about the cone, and we are doing this every time with the TAVI, and try to put it slowly, and then you check the gradient. For sure it will be no gradient, it will be free PR, and there is no any leak behind the stent. After that, you will take out your dry seal out, and you will go directly with the Sapien 329 valve. And as you see here, the cone of this delivery system is almost 28.5. So this is why we like to prepare it with the 24 sheath and also to put the ProGlide. Here it's very important not to push the stent while you are introducing the delivery for the Sapien valve. So usually we'll depend on the AB view and also the lateral view, and we'll try to centralize the cone as much as possible by pulling the wire. So as you see here, now we pull the wire, we took the wire out from the outer curvature of the pulmonary artery. Then usually we'll try to find the way to keep these 3 dots in the same line. So after that, you will unsheath it, because as you know, it is already on the balloon and it is covered. The whole system is covered. So during unsheathing, you don't want to go, sometime during the unsheath, this will push the valve inside the pulmonary artery. So you have to be very careful, because once you catch the upper tip of the stent, it will be very difficult to release it. Although still with a wire, you can do this, but you want to avoid this stressful event. And after that, you will keep exactly the stent, the marker in the middle of the stent. This is how you will unsheath it. You will fix with the right hand, you will fix the orange handle, and then you will unsheath it completely, then you will lock it. Then actually with the wire, you will try to centralize it. As you see here, these 3 dots in the same line, you want to keep it in the middle of the valve. You don't need any pace during the inflation, because it is low pressure system. You will inflate it slowly as you are doing this in the mitral valve or the tricuspid valve and valve. As you hear, there is significant parallax, but it's fine. It's clear from the lateral view that we are in the middle of the pre-stent. Then after that, for sure, you will release the wire using you will take out the delivery system. Then again, you will put the 24 dry seal before taking an angiogram. This is why I prefer to use it from the beginning. And after that, you will take the stiff wire with a JR catheter or whatever catheter, and you will check the gradient. We will be sure there is no any paravalvular leak. So actually, I feel this, for us as an adult cardiology interventionist and structural, it is very easier than other procedure for the mitral or the tricuspid valve. That's it, and thank you very much. Any questions?
I guess maybe one question for maybe for Dr. Jamila about the assessment. What would you have a problem with the assessment of this patient, or do you need more further imaging CT/MR for this patient?
Definitely, when we talk about the right side valves, echo play a role. However, the other imaging modality will definitely add to the assessment of the valve structure, valve anatomical location, as well as function. Dr. Bandar, this is an excellent case. I think you mentioned 2 important points from the echo perspective when we follow these patients, which is the gradient as well as the paravalvular leak. Now, I understand there are different platforms for the valve in pulmonary percutaneous replacement. So is there any different expectation for us as an echocardiographer?
Yeah. Really, actually, what is important for us from echo to rule out paravalvular leak? Because really sometimes the turbulence flow of over the pulmonary valve, after implanting the pulmonary valve, this will overestimate the gradient, which is not true. Usually during the procedure, we have like a gradient of, let's say, 10 or 5, and the next day they will tell us the gradient around 20.
Okay.
So actually this is like the echo is not that much accurate in assessing the gradient post pulmonary valve replacement, because usually we are taking this patient if they are symptomatic and we are checking the gradient invasively, it will become normal gradient, because really the turbulence flow by itself can overestimate the gradient of the pulmonary valve.
Absolutely, and I think the complex structure of the RVOT, as you mentioned, Dr.
Yeah,
Ahmed,
it is.
in CT, that will be a differently better assessment.
So I just, if the final comment from like, because of the time, maybe very short comment maybe, or if there's any comment from the panelists.
Just, Dr. Ahmed, I think severe PR is not a benign disease. It is to affect the right ventricle, and it has to be dealt up as soon as possible.
Yeah. That was a great session. Thank you for all.
Thank you.
Thank you.